Do it.
All right. It's always a little odd introducing yourself. My name's Chris Mazzola. Uh, I am a general dentist. I am a lead faculty for E3 at Pinky. I get to teach photography and I get to teach mastering treatment planning with my buddy Charlie Ward, who's the other guy on this call.
Mhm.
Um, we get to write a little bit for dental economics. We've got another business that we run together called Case, helping people through treatment planning problems. And, that's something where we really, through, our teaching at the Institute, found that some people struggle. So we're going to kind of dive into that a little bit today with 2D and 3D management and a little bit of treatment planning. Charlie's going to do that. I'm going to talk a little bit about how we collect good data. Yeah, go for it, Charlie.
Yeah, so Charlie Ward, most of what Chris said, we've done together, teaching a lot at the Institute together, E3. I teach in the aesthetics course with Lee Brady, Mac McDonald, Josh Polanski, Britt Shiner, um, which is excellent. So you'll see some of that stuff tonight that we talk about in that course. I'm a general dentist. I work with my partner, Devin, and my wife, who's a periodontist in Baltimore. And like Chris said, a lot of what we're doing right now is just seeing how we can be of service to the profession. Webinars like this, teaching at Panky and in other local meetings throughout the United States, things online, um, the column like Chris said, just things that we can do hopefully to move the needle a little bit for dentists like us who are out there practicing and in the grind, if you will. So Chris is going to get things started for us, and then I'll hop on. We'll kind of trade.
With my family. This is my family. Got a beautiful wife and three kids. My son Baylor there is racing at a national ski race in Colorado, not knowing that he was going to qualify for it. I agreed to do this webinar on a day that he is racing Super G, and he had a great day. So that's my family. I've got two daughters there, Eliana and Rose, my wife Christina, who's also a dentist. Obviously, I wouldn't be able to do these awesome things that I get to do with Charlie if it wasn't because of my lovely wife holding down the fort. This is my team. We are a very large team. We're 30. We get to have a little bit of fun. For those of you who know a little bit about the Pinky Institute, the current chairman of the board is about five people over there on the right side of your screen. It's Dr. Dave Swan. He was our partner. He came to our practice in 1994 and he just officially retired last June. We do miss him greatly if he's on this call. If he's not, he's probably doing something more fun. I was a chemical engineer before I was a dentist, so research to me is very important. There's some people that I follow in dentistry. Um, One being Tassir Suleiman, if you don't know him, he is a good buddy of both of ours. He's a researcher, material science at UNC, and he researches with the intent to help the general dentist. So when you read his stuff, it's about how it can help you in your practice life, not in some, cold sterile lab. You've got Nate Lawson there, who's fantastic. Blatz is fantastic. Those are both good follows on Instagram. And then Marta and John, they have done a lot for the digital world of dentistry, and that's what we're going to talk about from my section here. And you can primarily see what they release in both the JPD, Journal of Prosthetic Dentistry, and JURD, which is the Journal of Aesthetic and Restorative Dentistry. So for me today, one of the things that you have to be able to do as a general dentist is see where do we develop error. And when you think about the analog way, it's quite amazing that things actually come together the way that they do. In school, we're taught how to mix and spatulate impression materials with the correct water to power ratio. We then take that impression and pour it up and try to make a custom tray or try to take a prefab tray and properly size it to what we have there to take a final impression that we're taught to critique. Do we see any pulls? voids? Did we have any moisture issues? Did I get a clean impression of the area that we're trying to collect good data on? And then you go to the lab, and are we properly mixing the stone with the correct powder to water ratio? Are we pouring the stone into the to the impression on a vibrating table so you get the stone to flow properly? Did we wait the correct time setting before we took the impression and the model apart? Did we evaluate the model properly, right? Are they a good representation of what we saw in the mouth? Did we trim our models and our dies correctly? So now we've got this beautiful impression with all of those things that we just somehow got correct. Now we have to make that a representation of the patient, okay? So we are taking a face bow that hopefully we have oriented in the correct plane that we're going to be able to then use to mount the maxilla on our articulator to then take a bite that we took intraorally in some position, whether it's MIPCR or, excuse me, MIPCR or adaptive centric posture, and then mount the mandible to that, and then we get to start to build whatever we're building. So really right now we're living in more of this digitalog environment to where we're doing a little bit analog, a little bit digital. We're always going to end up having to go back to the analog world because the patient is analog. They're not in the digital world. So what we try to do is get really good data from intraoral scans and photography to try to build a person in either 2D or 3D. That's what Charlie's going to go into later, to get the most accurate representation of the patient that we see in front of us. And so what we're going to look at is we're going to look at for this evening is understanding what scanning errors are. Okay. So in the world that we're thinking about, when you have your intraoral scanner, there's two types. You have the operator, which is us, the clinician, and then we have patient-related errors. And that can be access or anatomy, or just quite frankly, people that are really fun to work on. So when we look, and we're starting to look at these scanning errors, the first error that we're going to look at is something called a mesh hole scanning error. Okay. So basically, it's just missing information in your digital scan. Oftentimes, it's unintentional. You're just kind of moving around your scan and you miss a little bit of data. Sometimes it can be from moving a little too fast. Sometimes it can be moving your wand in a way that is outside of what the manufacturer says you should do. And then the issue with trying to go pick that data back up when you scan back over it, you're layering data on data, which it's like relining an impression that's not meant to be relined. And you're adding volume to something, ours in the digital space in this sense, to where you are then going to reduce the accuracy of your intraoral scan. So when you see these, you really have a couple options. Like if you were working there, what is that, tooth number 12, the one that's the easiest to see? If you're not working on tooth number 12, do you really need to go scan that, rescan that? Is it really going to get you anything by going there? Or the other one is the distal of number 15, right? If you're not using that for something, it's okay to leave the data rather than layering a bunch of data on top of itself. So that's my one little bit of advice, is just be smart with if you're going to do a rescan, because as you layer, you're just introducing error into your digital impression. So the next thing is called a stitching scanning error. So it's a defect that you see typically as you move from buccal to lingual. And if you look at picture A there, you can kind of see it's almost like an irregular edge. And that happens when you have a scanning path that doesn't have common data. So typically, as you're rolling from buccal to lingual, you're moving too quick, and it doesn't have time to pick up enough of the lingual to incisal edge, and then incisal edge to buccal as you roll. So you'll see it as that abrupt border. It can also be seen when you're scanning scan bodies, which is picture B there. If you look closely, the closest line that you see to the left, you can see that jagged pattern that's there. Most of the time, this is caused from either moisture or just moving the wand too fast. So hovering for a little bit, letting the camera catch up and pick up data is how you will avoid these. And I will tell you, trying to rescan or cut these pieces out is not a good idea. Um, it will lead to distortion of your model in the digital space, which is a kind of a hard thing to wrap your brain around, especially in the anterior area. If the data is not right, you will actually make the arch more narrow or more wide than what it actually is. And so when you're doing any anterior work, you're going to get back stuff that then is either too broad and the contacts are really tight, or very, very light when you go to floss through it. Sometimes you won't even have contacts. So again, this is one of those, if it was me, this is so important, I would just rescan. That's the beauty. You don't have to take another impression.
Mhm.
Okay, so next is your tissue scanning error. Okay. And this is when you're moving and you probably don't have proper retraction. So you're picking up your cheek, the tongue, or even every once in a while you pick up one of your fingers. You'll see a little glove that gets scanned in there. So what happens is you then have to make a choice of, do I cut this out and rescan? Again, we're continuing to beat this rescanning part of this kind of to death. Um, it's going to introduce error. So what I do is I use an gate for almost everything that I scan, and that's going to pull one of your variables away. The cheeks are then out of the way, the lips are out of the way. Then if you're scanning the mandible, the only thing you have to worry about is the tongue, and you can get through and you get all your scanning in. And then the maxilla, the beautiful thing is you don't have anything to worry about. It's just following the correct path that the manufacturer says you should for your wand. That's how you'll minimize the error. What's starting to happen more now is in a lot of these um, rendering softwares, there's AI that's built into it. And so you end up with something that's called the cleaning function, where basically it will recognize a lip, a cheek, a tongue, a finger, and it will cleave it out of the way while it's generating its rendering, eliminating some of the error, which is great. So again, if you're scanning, it's a final scan and you pick up a cheek or tongue and you don't have AI that's built into your scanner that's going to help clear that out of the way, and you go and you take your wand and you, or your cursor, excuse me, and you delete it out of there, as long as you're not going to have to go back to rescan, it's fine. You can move forward. But if you're missing data, you really have to check yourself on whether or not this is going to give you back what you want from a final impression standpoint. Um, we have the next is called a reliability scanning error. This is something new from a tech standpoint. And basically, what it is it lights the model up and it shows you where your acquired data is unreliable or insufficient. So when you look at the green model that's in front of you, all of that red, the computer's telling you, hey, I don't have enough data there to be confident that I am going to give you a digital model that is going to be accurate. And so a lot of the companies are building this right now. If you have a Medit, you're lucky. This is actually coming from a Medit scan, and it will tell you where your data is not strong enough, meaning it doesn't have enough zeros and ones to build that 3D model the way that it needs to. The biggest advantage is you can see it in real time, and it's not going to take a computer algorithm and kind of lay data the way that it thinks that it should be. When you look at where it is on this photo, it's not critical, but if you could imagine that was on a deep margin, I mean, that's going to affect the long-term success of your restoration. If it's making up data, you lose the whole purpose of the accuracy. So the reliability scanning function here, we will see it as these new versions pop up. But like I said, Medit's a little bit ahead of the schedule here, and I think it's a really good thing that we're able to push through this digital data. The umbrella scanning error is it's a little hard to understand what this is, and I'm going to try to break it down as clearly as I can. So if you've taken a preliminary scan before you start your prep, and you go and you cut out the tooth that you're working on. If you don't cut out enough, you go to rescan, the computer gets confused on where to lay this data, and you end up with this hole there called this umbrella hole, where basically you see these little arrows the computer is going to show you that says, hey, the data here is funky. You either need to start over, like we talked about, when you're getting bad data, it's better off just to start over, or cut that spot out if you're comfortable and restitch it over with additional scanning. Now, I would tell you if it's in a non-critical error somewhere on the palate or the vestibule or a different tooth, sure, go for it. This is showing you a photo where it's on the margin of your prep. I'm not going to send that to my ceramist because the computer is going to make up where the margin is, kind of like when in old school they had a little bleb on the margin. They would just take their little discoid cleoid and knock it off and pretend like it was good. And it's still going to be a good fit, but again, we're trying to maximize efficiency and accuracy. You're better off rescanning when you see like things like this pop up. This is a little bit harder of a one to see. This is called a scanning noise error, and you're going to see it as surface roughness that's not really there in your scan. It doesn't actually exist. So when you see things like this, it's from really one of three things: poor lighting, you see it a lot happen on gold restorations, or you just didn't dry well enough. If you got a scan like this, you just need to rescan because you don't really know where that saliva went to, and that's going to really decrease the accuracy of your scan. And again, the whole purpose of this data is that we're going to give ourselves something that's a whole lot more accurate than what a standard analog impression is going to give you. So again, it's an awareness of these things that we're seeing on the computer screen rather than evaluating the impression that was typically sitting in our hands. I believe this is the last operator scanning error. And this is, so ISB stands for implant scan body. And what it is, when the implant's placed, I know all of our specialists or people who place, like myself, we always place them in the absolute perfect position. So when we go and we put that scan body on, we've got equal distance on the mesial and the distal to where the computer's not trying to figure out what's actually happening between those two. So when you look at that first picture there, you see that little weird little bubble that's coming out there. That's because the data, the scanner can't see exactly what's happening there. So it's making up what it thinks it is. The one on the other side over here, that probably happened because of insufficient data, and then it built out what it thought it was. So the wand moved too quick, and then you're back, and then it just didn't have enough time to layer enough of these digital photos and build a 3D model. So again, it's the slow correct pattern that's going to help you avoid the picture on the right. The picture on the left is going to be hanging out there for a little bit, and that you still might not be able to get rid of that depending on how close that implant scan body is to the adjacent tooth. So now we're going to talk about the patient-related scanning errors. So this first one is pretty obvious. I mean, the humidity scanning error, it's going to look like a bubble. It's really easy to see in the colorless visualization. So you're looking at a stone model digitally, which is the one on the left. The one on the right, you kind of look dead center. You can kind of see the photo there. You can also see in green where we have a mesh hole problem where you didn't get enough of the data there. So you see two errors on the one on the left, or on the right, excuse me. In moisture reduces our accuracy. It'd be no different if we were taking an impression, if we're doing a digital impression. So again, make sure that you're isolating the field and that you're drying the surface as well as you can. This next one is, it's called a bridge scanning error. So when you look at the picture that is on the left, you see that there was like a minor diastema there to where the camera can't quite pick up the differentiation between the two of those teeth. And it puts, I'm gonna call it a bleb, this little extra data that's there that's not really supposed to be there. And basically, you get this weird anomaly or bridge that starts connecting structures. When you look at the photo on the right of the prep tooth, where you can see someone did a pretty darn good job packing cord, but most likely what happened is that there might have been a little flick of tissue or something that then helped to connect that bridge. So now you don't have a complete clear separation between tooth structure and soft tissue. Where does that matter? Well, when you're in the lab and this was an analog impression and an analog die, you could go in there and you could trim that really easily. Digital world, you can't do that. I mean, if the data is overlaying the margin and you go to build a crown in the digital world on that, that data is just, it's actually too much data. It's bulked up over. So when you really are critiquing your final scans, this is a patient-related problem. You got to clear the data out or you got to take your final scan over because they won't be able to give you a crisp digital die from the photo there on the right. When we look at why this happens, it can be limitations that is outside of our control. You know, we have very, very powerful rendering systems, both hardware and software that are built into all these computers, that most of them do a pretty fantastic job of clearing this stuff out and picking it up. But I mean, we're asking a lot out of a wand that's about, you know, the camera's about the size of the end of my thumb to be able to give you something that's so incredibly accurate. So we need to set up an environment for success. You know, we look, those are the areas we're talking about there. Um, this is a big one. It's called, believe it or not, by definition, a fuzzy finish line. So this is what happens when you didn't really capture enough data, or if we're going to put it on ourselves, it's really because it's just bad soft tissue management. You know, it's probably the lack of a double cord technique, or if you're going to pack one big cord, or you just didn't pack a cord at all, and you tried to scan because you thought you could see your margin clearly, which by the naked eye, you look at it, you could probably guess where it is. But again, maximizing accuracy and precision to be able to move and build this person in the 3D world, you're not really getting that, especially in picture C, which is one of Charlie's preps. I don't know if you're looking at that, Charlie, but
I can see it, and that's rude. That's
yeah.
what I think about it.
So, you know, we're soft tissue management is critical, especially when you're equigingival or below the gum line. You got to make sure anything that's, you know, high water in the digital space is fantastic. You don't need to worry about any of that. And, you know, the double retraction cord technique, it's just going to help to push that tissue out of the way. All right. I believe this is our final one here, Charlie. It's called scannability noise error. And basically, this is when you have limited access based on the patient's anatomy. So when you put that scan body in there, it's basically kissing that adjacent tooth. There's no way for the camera to be able to pick up what's happening 2 millimeters below where that contact is. Or again, if you look at the picture on the right, I mean, it looks like, I believe that's a lower canine there, is just bumping up against that, or an upper canine. I don't even know. It's just, you can just tell everything is too tight. You're not giving it enough space for the camera to be able to pick up the video and lay down the model and build something in the 3D world. So, you know, that now that when we were in school, we learned to pick out the errors. It was almost beat into us. So when you take a analog impression, in my experience, no one really dives into these digital errors for you to be able to analyze. You don't really need to memorize these 10 things and their definitions, but just the awareness of, hey, this is good, or hey, this is not good. I need to rescan so my laboratory doesn't make something up. And so when you take good data and then you take photography at the Pankey Institute taught by Charlie and I, but you take that with you to then build something in the 2D or 3D space, that's how you can continue to flow through and build something that is both precise and accurate. So I'm going to stop sharing my screen here for a second. Charlie's going to jump in and he's going to jump into both 2D and 3D planning now that we have good data.
Hey, Chris, hop on the Q&A there. We had two questions about scanning errors and sort of rescanning. I know we'll do a actual Q&A at the end, but just give me a second to get ready.
Um, if rescanning creates errors, can we create a brand new scan deleting the previous one? Yes, you can. You just there's usually, like, I think about my trios. If I'm in a window and I'm looking at the left side, there is a clear scan button. You just clear that and it brings the screen back to whatever it was before you started scanning. That's what I would do. But I remember writing my rescanning. Is it the intent to erase and rescan, or just the one crown or the whole limit? So this is where you, William, this is where you have to make a decision as the clinician. So yes, you can clear that little bit of data out and rescan, as long as, since you pulled your cord, the soft tissue didn't continue to collapse in, changing the data around it. So if it was me, I would go back, I would clear out my final scan if I had taken a preliminary scan, or I'm starting over, because there's no way after you're sitting there evaluating your scan that that tissue has not moved in that 20, 30 seconds that it took you to look at it and then clear it and then get back in there with your assistant, dry it off, suction. Now they're coughing, right? It's like there's no way that you can, that the data won't overlay very well, and it will give you now probably a fuzzy error rather than the bridge error.
Yeah.
What's my
Chris, I'll,
favorite scanner? So Trios, if you talk to any buddy on the lab side, they're going to tell you for Crown and Bridge, Trios is the best because they can use 3Shape shot software and they love the data that comes from there. There's not a lab that I know that likes doing veneers off of a scan. I still take a traditional analog impression. I know, Charlie, you do the same thing,
Mhm.
unless they're, I'm going to say, not a traditional veneer. If they're, Charlie could explain this better, but more of a aggressive veneer prep. Well, then they got all sorts of daylight. You can scan that and they can build them off there.
Yeah. Chris, let me I'll go through this and then we'll hit all of them in the Q&A at the end.
Perfect.
See what else comes through.
All right, buddy. It's
So
yours.
keep throwing questions in the chat or the Q&A, and we have time at the end. We'll go through everything with everyone, but I want to keep it moving for you guys so we get through all of it. So Chris, Chris made the point. Um, there's a lot of error that can be introduced, not just obviously in the analog workflow, but since most of us are scanning nowadays, we have to know what these errors are and how to manage them, because everything is going to build on everything else, right? There's no shortcut to get to the end of it. And the more error we introduce at the beginning, the worse things are going to be as we move along. So my hope is that, and our hope is that we get good data at the beginning to do our planning with. And if we spend the time in the planning portion, then as we work through the case, we've created a foundation or a framework that we can be accurate all the way through, or as accurate as possible. So our goal is to get to a point where we can take the correct photographs to do the planning, like Chris said, in 2D and then eventually 3D, and then execute the case in a way that's reliable and predictable, without the stresses that can come up with any type of dentistry we're doing, not just the aesthetic dentistry that we'll show you here. So the goal here really of this presentation, is sort of interactive case management, is that there's lots of different tools that we can use to help us in planning our cases, right? So um, full disclosure for me, I'm going to show you a product by Align Technologies. They are not paying me to be here, but I am a speaker for them. I'm going to show you Smile Architect because that's a 2D and 3D planning um, product that's been a good addition, I think, to my Invisalign. And then same as Chris, like none of this is possible without my wife, who's also a dentist, periodontist, who works with us and our kids. Um, they are luckily in bed, and I haven't seen them sneak up behind me yet. So if a child runs in here, please forgive me, because it could happen. So I like to think about the way that I plan these cases um, in the way I heard Peyton Manning on a podcast not too long ago talk about sort of his career and his preparation. And he said, I know that I knew always that I wasn't the best athlete on the field. I didn't have the strongest arm. I wasn't the fastest guy, but no one was going to out prepare me, right? I was going to study harder. I was going to plan better. I was going to know every team that I was playing, all the tendencies. I knew everyone on the field, so I would not be out prepared, right? That's the way I think about it when I'm trying to set up a case. I want to work through as much of it as I possibly can so that I'm as prepared as possible when it's time to prep, right? I don't want stress in those procedures, and I shouldn't have it because I've done my planning in the correct way. And exactly like Chris said, I want good data at the beginning so my planning's accurate, so that I know if I execute the way that I've planned it, then we're going to be good to go. Right. So when we think about the tools that we have, it really starts with aesthetic diagnosis, right? When we're planning a larger case, um, we are going to need to make some aesthetic diagnosis to figure out what is actually going on and what's the best way to treat it. We are not going to talk about aesthetic diagnosis tonight. That's not really what we're doing. If you want to learn about that, go through the curriculum at Penke. We do that in E3, and we definitely do that in the aesthetics course. What we're going to focus on are the 2D and 3D tools that we can use in that planning process to help us make treatment planning decisions, right? And eventually get to a 3D design that we can take to the mouth. So in 2D, we can use Keynote or PowerPoint. We can use Trios Smile Design for those of you that have a Trios. It is on your Trios. I will demo that for you. And then in 3D, Invisalign Smile Architect, I will show you, allows you to do the ortho planning and the restorative planning together. And then Exocad or 3Shape to do your actual 3D designs. Now, Chris and I are on the same page with this. We have friends that love to do their own designs. They're dentists. That is their choice, and I'm happy for them. I do not have the time or capacity to learn Exocad in the way that my lab knows it and can do my designs. But if you so desire, then by all means, learn that system and take control of your cases. So when we're doing this, just like Chris was saying, the accuracy of the scan is important or essential. Photography is essential, right? If we're going to be using 2D smile design and eventually 3D smile design, we have to be able to take good photographs in the correct orientation to be able to do truly facially generated treatment planning. So we're not going to look at an entire diagnostic series of photographs here. We're going to focus on these couple that are really, really important. And the first being lips at rest, right? We need a repose photo to start our planning. Why? Because we need to know where the incisal edge is going to be, right? We have to start with this photo. So if you're going to send a case to Chris and I to look at, to any mentor to look at, this should be the first photo that you're looking at, right? I need to know where the incisal edge is at rest and if I need to add, subtract, whatever the case may be. So we need to be able to take this photo. I like to see it in a full face and a close up. It just allows me to have the extra data that I need there. But this is the most important one. Okay. If I'm looking at a full face photo, right, I want to see the whole head. I want to see above the top of the head, below the chin. I want the patient to have a neutral head posture, right? So if they were looking straight at me, gentlemen tend to tip their chins up. Women will sometimes turn to one side, subconsciously or consciously. Make sure that your patient is looking straight towards you. The best way to do that is to look at the temples and make sure the temples on both sides of the head are even, right? Eyes forward, I tell them to look down the barrel of the camera, and then I want hair tucked behind the ears, right? So you can see in this patient, he's directly facing me. And then if I take a smile photo, I should be able to overlay those two things, right? Same position. And then if I'm doing my 3D planning, I really want a big smile with the teeth apart. And what that's going to do is allow me to take the scans that Chris was talking about and incorporate the 3D STL file scan into the patient's face. We'll see that in a second. So if I get a really big smile here, then now I can see all the incisal edges, right? And now I'll be able to take that STL file and accurately incorporate that into this 2D photo and do my planning, like you saw in the intro video. We'll look at that again in a second. Okay, so this is the data that Chris is talking about from a photography standpoint, right? If I can take an accurate scan and I can take accurate photography, then I can work in the 3D world and build a smile in the patient's face, right? This gives us a huge advantage because we're planning things. Again, this is what Josh Polanski, our ceramist, would call the virtual patient, right? Can I create a virtual patient here where I can work in 2 and 3 dimensions to build an appropriate smile design? So when we look close up at this patient and we're doing our design work, if you look closely there, you can see where I use Trio Smile Design to do the outlines of this patient. So we're setting the smile curve there. We're setting new proportions to do 6 through 11 here on this patient. And then you'll see as we do a simulation there, yes, those canines are a little aggressive. That's what he wanted, and you'll see that in a second. Now I have the ability to show the patient in their own face this simulation. Okay, and the one you're seeing here, like I said, is from Trios. This is their smile design software. But if I get to this point, I can send this to my laboratory and they can do a 3D design for me that then I can work from, right? So that's what you're going to see here. So I've taken my scans accurately, as Chris said. I've taken that same 2D image, sent that to the lab. They incorporate those things, right? And now they can build in this 3D design into the patient's face. Now they're moving it side to side. Obviously, the 2D photo is not really moving side to side, but you can see how that would be built in, and now we can plan that in the patient's face. Right? So if I approve this design, they send it back to me. I can print it, they can print it, but I can take the patient from here, right? There's my 2D simulation that I did in Trios, and there's the provisionals in that patient which they built, right? And that's a pretty darn close match, right? So we simulated it, we planned it, we did it in 3D, we take it to the mouth, we can get that result from there. And then I can take the provisionals here, right? Because we're working in a digital world in this case, I can scan this, and then the lab should be able to transition from the provisional to the final seamlessly, right? That should be a seamless transition to final restoration, okay? But it all starts with accurate data, right? So accurate data at the beginning, properly planned, right? 2D and then 3D, and then executed out to the end, right? No surprises. And if there are, we've anticipated those things. So we're going to do a little bit of I'm going to call it smile design here, just so we're all on the same page. But in the young female, right, we'd expect to see 3 to 4 millimeters of tooth structure at rest. Okay, males are going to be slightly less in most cases. But again, this is where we start our planning. Okay, we have to start here. If I don't have this photo, I don't know where to set the incisal edge. I can't do anything past this point. It's just a guess, right? And our whole goal is to reduce, if not eliminate, error. So when we're starting here, we set the incisal edge first, okay? And we have to remember there's a lot of different lip shapes for us to have to deal with. And the amount of display at rest changes as we age, right? So a 29-year-old patient is going to have different display than a 49-year-old patient. It's going to have different display than a 65-year-old patient, right? A 65-year-old patient that shows 4 or 5 millimeters of tooth structure is probably going to look a little funny, right? It's not going to look as natural in that patient. So again, there's an art and a science here that we have to deal with, but we're still starting with display at rest. That's our goal, okay? Now, once we know where the incisal edge is, we start with that position and now we build tooth proportion in, okay? So let's say in this case, and again, we're not talking about aesthetic diagnosis. I'm going to try to avoid it as much as I can, but I can't help it. So if I start at a proposed incisal edge position, right, based on a lips at rest photo, let's assume it's right here for this patient who's had some compensatory eruption with wear here. Now I can draw in a tooth proportion somewhere in the 70 to 90 percent range. Okay. So if I draw that in, there's one at 80, there's one at 75. Okay. We'll notice that new proposed gingival level um, would require some type of ortho intrusion or crown lengthening or something, right? But what that gives us now, if we go ahead and do all the other teeth, is the 2D version of this smile design. Okay, so this sets the ideal gingival position for this patient. Okay, so start with incisal edge based on the lips at rest photo. Build back. I usually use 80%, right? I'm using the width of the tooth as it is, unless I have spaces. I'll build 80% first and just see how that looks in someone's smile. Okay. But once I figure that out, that then will give me the ideal gingival position. Okay. So now when I start looking at where am I going to put teeth in the face, I do have a bit of a checklist that I'll work through. Um, and this is helpful. You can, again, this isn't proprietary. This is a mix of Christian Coachman Smile Design and Penke Smile Design and John Coyce and everything I've read on the internet. It just helps me as a checklist. Um, and this is what that would look like in practice, right? So first thing I'm going to do is set the incisal edge. So does this incisal edge look appropriate for this patient who's in her 30s? Yeah, she has nice display at rest. Her lip shape is normal. So I'm not going to change that incisal edge position. Okay, if I go to her face and I draw some lines in here, make sure my interpupillary line is level, and I draw a facial midline, do I need to change the dental midline? No, it's right on the money, right? So I know when I do my design, incisal edge is going to stay the same for this patient, and dental midline is going to stay the same for this patient. So now I'll look at smile curve. Okay, ideally I would like the incisal edge to follow the curve of the lower lip, right? And that looks pretty nice. So I'm not going to make any changes there. Okay. Now I'll look at central incisor proportion. She's more than 90%, right? So she has short teeth. So I know that I'm going to make a change. So if I come up close here and I draw this, she's at 90%. If I draw her at 80%, keeping the incisal edge the same, you can see that we'd need to do crown lengthening or something once we make the appropriate diagnosis. And I start looking at gingival architecture and gingival level, right? Papilla height looks good, but you can see the step in the gingival levels from the canines to the premolars, right? You can see she has short centrals. So I'm going to need to make changes here. And you saw in her smile how gummy she was. Um, so papilla levels are good, but we need to probably raise things up. Okay, and if I look at that smile again and I look at the buccal corridor, she has a nice fill there. She's just gummy in the anterior and the posterior. So I'm not worried about necessarily widening the arch. In this case, I just would like her to be um, a little less gummy. If I look at things occlusally now, I see, oh, she's got spaces, right? So she's got short teeth and she has spaces. So I really, if I'm going to make an aesthetic change here, need that height. Otherwise, I'm going to have teeth that are over 100% in the width length ratio. And then as I look at my last photo, I'll look at either 12 o'clock view or these lateral views just to check the incisal edge to the wet dry border. And she's already in a good place. So I wouldn't want to bring her teeth forward at all. They certainly don't need to go back. So I can start to make assessments there about where do I want teeth two-dimensionally and three-dimensionally as I start to do my design. So I can then communicate that with my laboratory uh, once I have some of my planning done. So here's a tool that I love to use and use it honestly for most of my cases where I'm doing aesthetic dentistry. So if you have a Trios, this is Trios Smile Design. I'll show you how to do it. It's about 2 minute and 30-second video here. So I sped it up. It takes about 5 minutes for me to do this. So if you open up a case for a patient, you click on Smile Design, it'll open it up here. And all you really need is a wide smile photo. If you have a big smile photo, you can do this for your patient. Now, don't do it in front of the patient for the first time. Practice it a couple times before you do. Okay. But if you upload the photo, it's going to put some dots in. You're going to align the pupillary lines. You're going to move these dots around into the right spaces. And once you get them right and you click next, then you're going to get an outline of some tooth forms. Now it's going to automatically pick a form that it thinks is right. And sometimes it is, and most of the time it's not. But there's lots of different choices on there for sizes and shapes. So get one that you like the look of. Now you can alter this in every dimension. I'll show you as we go through it. So you can change the smile curve. You can add or remove teeth on here, right? So I'll just show you 6 through 11. You can work symmetrically. You can work linked, right? I'm changing the width of the lateral here, the length of the canine, and I'm trying based on that checklist that I had to say, okay, my midline is where I wanted it. I'm not changing the incisal edge position. I know that the smile is gummy, so I'm going to raise my gingival margin. Okay, I realize we're not talking about actual treatment here. That's not the goal. And then if I click on the right side of the screen there, you can see it brings up my ratios. So I'm going to shoot for 80% like we talked about and just see where that puts me with that patient. Okay, and then I'm going to design the rest of the teeth to fit that. Okay, and as you start to play with it a little bit, you can turn the symmetric design on and off. And if you click that green part, the freeform, you can change the shape itself. But once you're ready and you click next, it'll take you to the actual simulation where you can change the color of the teeth, the texture, which is really about light reflection, into anything that you like. So click through to find the one that looks the best on that patient, right? And then you can see, again, what the simulation would look like in the patient's face. And this is a great tool to show the patient to say, hey, if these teeth were the right proportion, that's really how much tissue we would need to remove and how big these teeth would look, right? And this is a cool version of it because we only did 6 through 11 here, but you can see that she has altered passive eruption all the way back. Like she would really aesthetically need crown lengthening to her first molar to make this aesthetically look the way that we wanted it to look. So this is what I would share with the patient for her or anyone else to see, to say, hey, this is what we're thinking about, to address the aesthetic needs that you discussed. How does this look? What would you change? But it's a great tool to use. And like I said, we do it all the time. Here's a case that we did. We can actually plan the lower arch as well. We just planned this one, I think 2 weeks ago. So again, his was just 7 through 10 and then 23 to 26. But you can see everything looks better once you make those anterior teeth look better. And then this one recently on a hygienist, we did 7 through 10 here for her and raised gingival margins on those as well. So great tool for the patient to see the differences between the two, right? So if you have a Trios, it is on there. All you need is a smile photo like this to use it. So please test it out. I think it's a very helpful tool. Now, we'll look quickly at Smile Architect here. So Smile Architect allows us to do the Invisalign planning with restoration in mind, right? So the goal here is for us to be able to know that we're going to restore certain teeth in the smile and that we're using the Invisalign to set up for that restorative. So we can ideally position the teeth to minimize preparation, right? Or let's say idealize preparation. So when we think about cases like this, it's really nice because you're actually doing a facially driven smile design here, right? So with ClinCheck, with the regular Invisalign, you're sending them photos so that they can see what it looks like, but we didn't have the ability to see what it looked like in the patient's face when we got it back. This changes that. It is free right now. And I say right now because who knows if it is going to remain free. So if you're an Invisalign provider, the only thing you'll need to do is take the patient's photo, the smile photo you see on the left, in the Invisalign app on your phone. You can take all the other pictures like normal, but that one has to be in the Invisalign app. wide smile, and then you can plan from there. And if you do that, there's lots of cases that work really nice with Smile Architect. Like if you have peg laterals and you want to set the lateral ideally in the space based on the restorative, this would be an ideal case for you, right? If you have damaged teeth, non-aesthetic teeth, as they say, that are worn or chipped, and you're going to intrude so that you can restore proper length, this would allow you to plan for that, right? Missing teeth. So let's say, again, with a lateral that you're missing a lateral and you want to create the proper space for the restorative, you can do that with measurement, right? You're not just sending this to ortho and say, create space for an implant. Like you can actually set this up so that you have an ideal situation. And then the compensatory eruption with wear, where you have uneven gingival levels and you want to level the tissue so that you can restore what's lost. Again, ideal situation so that you can see what that looks like. So this is what you would see in those cases. So if I play this through, if you look at the smile button up top, you're going to get a smile button and a restorative button or a restorations button. If I click the smile, you're going to see that smile image we saw earlier of the patient. This is the pre-op view, right? And the cool part is if you play it through and the restorations are off, you're going to simulate what the patient looks like without restorations, right? So this is what ortho will look like when they finish. So the patient's aware, hey, things might look a little funny when we get done. But if I turn the restorations on, now the patient can see the simulation with the restorations in place. Okay. And you can see there on the right that we've moved teeth into a position where we can be additive in whatever restorations we're going to end up doing, at least to the incisal edge. And then you can see as that moves through what that actually looks like. Now, the design here is not as sophisticated as Exocad. It is not meant to be. It does take a bit of work, but from a planning standpoint, I don't know of anything that incorporates these two things together as nicely as this does. And then again, the simulation is really well done. So I can show the patient, hey, this is where you started. This is where things are going to be after the ortho's done. And then this is what things will hopefully look like when we finish. And this was a case that we did not too long ago. So when she finished the ortho, I sent it to my lab to do the workup for the 3D and Exocad. And I didn't send them the initial, which you see there on the left. And this is what they sent me back. Which was pretty darn close to what we had planned in the actual Smile Architect. So we ended up doing this as injection molding for this patient, and this was our final result, which was awesome. We were so happy with it. She's actually one of our assistants. But when we see her next to her actual simulation, like that's good planning, right? That's good data at the beginning. That's good photography. That's good setup using a tool, again, like Smile Architect, that allows us to use that good data to get a nice result. Okay. Another case for Smile Architect. This is a pre-op view of it. You can see on the left there, you can have the facial lines drawn in so that you can follow that. You can adjust those, of course. And then you see a post-ortho, right, where we've idealized spaces here so that when we go to do our restorative treatment, she can see the simulation. She's obviously had a lot of wear. We're adding length and filling spaces. So when we see that close up, you can see that we've ideally positioned these teeth to minimize preparation, right? That's our goal here. So we go to 3D from there, right? We ended up actually doing 10 veneers here based on what she wanted to do. But we go to 3D and we can work from the 3D, right? To take her from there to there in the provisional, right? To there in the final. Okay, so if we see that start to finish, there's our before and after for, again, planned with Smile Architect to get her to a finished spot. So this is the last thing I'll show you guys. So let's say you're not an Invisalign provider, you don't have Exocad, you don't have a Trios, you're using something else. You don't need any of those things, right? I still use Keynote to plan a lot of my cases, if not all of them, get some little Keynote thing before I do anything. So here's a simple way that you can do this. Um, I'm going to start exactly the same way, right? I want a repose photo for this patient. It's a young patient, lots of display at rest. She has a gummy smile. She ends up having altered passive eruption, which you'll see in a second. So we're going to keep our incisal edge position the same, but we're going to design this case using Keynote. So if we look at our incisal edge, again, she's young. She probably has excess display, but she also has a high curve in her lip. So we're going to keep our incisal edge. We're going to figure out where this ideal gingival position should be. So this is what 80% looks like for her, right? So if I'm using that width length ratio, that's about where I'd want my gingival margin to be, okay? So if I like that, I can design my other teeth here, okay? And everything looks good from there. You can see how much tissue we need to remove there to make that more ideal, okay? Now, I have a little ruler down here, which I'll show you in a second. If I don't have the ability to figure these things out on my own and I want to know how much tissue I'm going to remove, if I know the length of that central incisor, and in this case, let's call it 8.5, and I'm making a 10 millimeter tooth, then I can put that on there. I can calibrate that ruler, right? So I drag that ruler so that it's 8.5 millimeters from incisal edge to gingival margin of the natural tooth, and that'll tell me and my periodontist or whoever's going to be doing this tissue work that I need to remove 1.5 millimeters, right? So that's an easy way to calibrate in this little 2D workflow to figure out how much tissue I need to remove. Okay. Now, if I look back at the smile for this patient, you can see those gingival margins are going to be right at or just under that upper lip, which would be ideal position for it. So that 80% was a good guess for us. And if I look, I've got my gingival margins where my laterals are just a little bit coronal to the gingival margins of the centrals and canines. So I like that design. So now I can go and I can have the surgery done, right? So we know she had altered passive eruption. We remove the necessary tissue there. And when we flap this case, you can see she actually has bone all the way to the CEJ, which is why she had a gummy smile, right? So again, my wife's a periodontist. This was her surgery. Now we can remove bone back to where it was supposed to be and reset that tissue and know that it's going to stay where it's supposed to. And that's what it does. So this is after she's healed from the surgery. And then we can go back in with that planning that we did earlier and only restore 8 and 9. Now she came in originally to have veneers on here, but we made an accurate diagnosis and did the crown lengthening to expose these beautiful teeth that she had underneath. And then we just decided that we were going to do really conservative feldspathic veneers on 8 and 9. You can see there we're shifting that midline just a little bit. So as we do that, and we take that to the mouth, there's our mock-up. We're going to cut this back very, very intentionally. We finish our preps there, super conservative. Okay, there's our provisional day of. We let it heal. It looks great. Okay, and then we can go to final, again, predictably for this patient with nice tissue health and a nice smile, just as we planned it. Okay, so good data at the beginning, planning appropriately and with intention in the middle so that we can execute at the end, right? But we're always starting with incisal edge position at repose and then building our smile out from there in those parameters. Okay, and there's our patient at the end. So we hope this stuff was helpful, right? That there's lots of tools out there for you guys to use. Keynote, PowerPoint, Trio Smile Design, and then in the 3D world, Smile Architect and Exocad or 3Shape. But again, good data and diagnosis before you get to this point. So we're kind of picking up on the back end, but if you have questions about diagnosis, there's lots of resources, Restorative Nation, Pankey Online, and of course the Essential Series. So if you haven't been to Pankey or you're looking for the next available courses, there's your QR code for the Essentials. Chris will be teaching E3 forever, I'm pretty sure, rest of his life. And if you just want to have fun, then you come hang out with us next summer, not this summer. This is 2026. We're offering this every other year with our friend Tal Wilkins, so Master in Dental Photography at the Bank Institute, July 30th to August 1st, 2026. And now we'll take some questions before we finish up.
Charlie, I'll run that Q&A for you if you want.
Yeah, what we got?
All right, first from Kristen. How much are you altering in the 3D design from the lab?
Mm. Um, that's a good question. Sometimes nothing. I just got one back today that was very minimal. Gingival margin, and that was a question between the two of us. So normally it's collaborative. I'm trying to give enough information to the lab to say, I want gingival margins to be here on the centrals. I want gingival margins to be here on the laterals. So usually there's minimal once we've established sort of what we like.
Coming from JoJo, do you still have a diagnostic wax up made by the lab at this point? And my assumption is that this came in early in your presentation. It's probably when you were doing 2D.
Okay. So I will say this because I'm not Chris will tell you I'm not dogmatic about anything. I don't think he's dogmatic about anything. Um, for me, if I'm putting actual wax on a model, I'm trying to figure out if something's going to work. If I'm doing an aesthetic case, and I am looking for a wax up or a planning, that's done digitally 100% of the time now. And it's no contest about what's the best way to do it. So yes, I'm doing that, but I don't order the actual 3D wax up until patient commits to treatment because that costs money, right? If my lab has to do an actual 3D design, they're going to charge me for it, and I'll charge the patient for it. So I don't order it to sell the case, if that answers other people's questions too.
From Antonia, does this only work with the newest iTero?
No, uh, no, you can do Smile Architect in with any scanner. So when you open up Invisalign to select your case type, Smile Architect will be in that list. And you can select that, and then you have the option to do it as comprehensive or moderate or whatever the case may be. I think you get 4 or 5 options there. But you can choose Smile Architect in there, but it won't run the Smile Architect for you unless you take that full face photo in the app.
Okay. From Maria, the injection molding, is that the David Clark method? And I'd say no, we learned it from the Dr. Tal Wilkins method a number of years ago at a Pinky Symposium. But a lot of a lot of people have a method for doing this. The way that
Yeah.
Charlie and I both do it is you get one model printed. That tooth, if let's say we're doing 6 through 11, that 6, 8, and 10 are a different design, are your wax up. You have that printed, you make a clear matrix, you Teflon tape the teeth that you're not injecting, air braid, etch bond, sit that thing on there, inject your deposit in, lightly finish, and then the other model that's printed is 6 through 11. You Teflon tape the teeth that you just did, air braid, etch bond, put the nuclear matrix on there that has the other 3 teeth, inject and finish.
Yeah.
Uh, but yeah, it's a fantastic method. You can do beautiful aesthetic work for a patient, especially if you're trying to make it a little easier for them to move into aesthetic dentistry and see what things can look like, and with the intent to hopefully someday convert that to porcelain. Charlie, you agree?
Yeah, absolutely. It's a great, inexpensive way to get a really nice result that can, even if that person got 7 years out of it, it would be great. And then you get a test drive of something that looks really nice, that's good for a patient that, eventually those can turn into porcelain. And even if they don't, it's still a good restoration for a patient.
All right, from an anonymous attendee. With the Smile Architect planning, how well does it simulate the zeniths with intrusion or
It's
starting?
garbage. It's trash, actually. It drives me absolutely crazy. Um, I don't understand uh how they even came up with it. Yeah, it's a pain. So I've found I have to go in, I have to reset the gingival margin on the restorations. Um, and it's only on the restoration. It seems to do well with the teeth, but the restoration itself is it's like it's not even thinking. So it's frustrating, that portion of it. Um, yeah, I'm sorry. I don't know why I'm apologizing. I didn't have anything to do with it, but I don't like it.
Coming from Antonia Collins, when you say removing tissue, do you mean bone for crown lengthening or gingivectomy?
Either.
Both.
Yeah, either. It depends. In most cases, you're probably removing bone in one way or another, to be honest, but could be either.
I have one from Tao. So do I export the Smile Architect design to the lab to get the workup design? Wow, I've not used Smile Architect so much. I need to use it more. And what lab do you recommend to get the injecting molding done? Not all labs do this. Thank you.
So first question, you can. So if you export it, you can actually export that model, and give that to the lab as a reference. I'm actually not doing that, but that is possible. Um, as far as design for injection molding, anyone that's doing um, digital design, like digital wax up, should be able to give you models for injection molding. You're just going to ask them to, I would hope, you would say, I'm going to do injection molding on this case. I need one model with every other tooth waxed up. So, like Chris was saying, if I'm doing 6 through 11, they're going to give me a model that has 6, 8, and 10 waxed up to the final form, but the other teeth are as they are now, pre-op. And then a second model that has all of the teeth 6 through 11 waxed up. And I use that first model with every other tooth to do my first build-ups. And then my second model to do the other ones. So again, if you watch that, I think Restorative Nation, Tal probably has a video on Restorative Nation um, for that. Any lab that's doing digital design, all they're doing is turning those other three teeth on and off to give you those models. So they should be able to do that. Can Evident do that, Chris? I mean, they should be able to do that.
Absolutely.
Yeah. So Evident is a really an online lab that does digital design very pretty cheaply and well. They should be able to do that. So it's EVIDENT. Evident is a lab that could do that. But if your lab's doing digital design, they should be able to do it.
We got two more, Charlie,
Go ahead.
um, for now.
Let's do it.
Sam, he says, how are you doing this on Keynote? How do you close cases chairside using an iPad in Keynote?
So I have tooth forms. Um, I have like a template essentially of tooth shapes that I use in Keynote. So I'm taking that photo, I'm dragging in those forms, I'm adapting them in Keynote. Um, but I'm not doing that. I'm not doing this chair side. Like when I have a consult or treatment planning appointment with a patient, I've done all of my homework. I've planned the case essentially to completion. I'm presenting what's appropriate to the patient at that time. You can, and I know people that do that same thing on an iPad or Keynote chair side with the patient. Like, they're using a pencil on an iPad and drawing those things in. My fear with doing things like that chair side is that if I do that planning and it doesn't look good chair side, um, then the case is over, right? Like I don't have a second chance to figure out how to fix it. Sometimes I do it in Trio Smile Design and I finish the case and I'm like, that doesn't look right. And I have to go back and I have to make changes to it to make it look right. Um, I don't want to find that out the first time in front of the patient. So that's why I just don't I prefer not to do it chairside with the patient.
Last one as of now, again from our friend, the anonymous attendee.
It's probably Dustin Kidder.
It probably is. Are the photos from the patient's comprehensive initial exam or an aesthetic consult?
Oh, could be either, to be
Hmm.
honest. Because I'm going to take similar photos at either visit. I always have the full face and always have the smile, always have the repose. So for me, it would be either of those things. I would still have it.
Okay.
Yep. And if you're looking at courses, symposium, anything Pancake related, there's your other QR codes. Um, if you guys have any interest in that. And yeah, reach out to us with anything. We'd be happy to answer questions.
Perfect. Thank you both
Cool.
so much again.
Thank you guys. Thanks for coming.
Thanks, Desi.